talking about today is central nervous system infections. We're going to start by talking about bacterial and viral meningitis, which we actually know quite a bit about and actually have treatment available and have prevention measures also available, which have really actually decreased the number of cases of bacterial meningitis that we see. After that, we're going to move on to the great unknown and talk about encephalitis, which there is much less to be known about and much that is still confusing. So let's get started. These are important infections, and the goals here are just to integrate the clinical, microbiologic, and immunologic factors of the central nervous system infections. So that's a highfalutin statement, but I would really like you to think about the organisms and the patients, and there will be a few, but because of limits of time, not a lot of case vignettes to discuss. And then this is definitely board relevant, and it's going to be clinically useful, and that's going to be your preparation for care of actual patients, where you need to keep these things in mind very often in patients with fever, and fever is a very common complaint. So definitions, all of these things can be medical emergencies. Meningitis is an infection of the covering of the brain, the meninges, and it will show up as fever, headache, neck stiffness, vomiting, signs of increased intracranial pressure, which can be changes in the vital signs with high or low blood pressure, for example, and minor alteration in the mental state or seizures. If it is limited to the meninges, those are the symptoms without necessarily affecting cognition. However, this can become deeper and cause, brain inflammation that will change cognition and consciousness. Encephalitis is an infection where there's definite abnormalities in the brain function. But because the brain is so complicated, these can be motor, they can be sensory, and they can be behavioral. And that is really sometimes very confusing, because is this person sort of classically crazy, or does this person have a brain inflammation or an injury that's explaining his odd behavior? Personality changes and movement disorders and speech disorders. And then you can sometimes have to say meningoencephalitis. In a severe meningitis, for example, where you know the meninges are involved, but you also know that the brain substance is involved, either by MRI or imaging or by the behavior of the patient. Myelitis, that's inflammation or infection of the spinal cord. So encephalomyelitis or meningomyelitis is when you have not just the brain covering, but also the covering of the spinal cord involved. Transverse myelitis, though, is more specific. This refers to a section of the spinal cord, that transverse section that is involved. And that's going to be very much more limited than when there's involvement of the entire spinal cord. Brain abscess is a discrete infection within the brain, and abscesses in the subdural space and outside the outside are epidural and subdural abscesses. So bacterial meningitis, it was almost uniformly fatal before antibiotics were available. So that is not so long ago. Certainly in the 1925s, almost everyone who got bacterial meningitis died of it. Now there are, even with the decreased amount that we're seeing, millions of cases annually worldwide. It's one of the 10 most common infectious causes of death. The mortality rate is still significant. It's greater than 7% in developed countries. And it's important to realize this probably hasn't changed much since 1970 or 1980, when antibiotics were available. That means that prevention is needed to prevent deaths, not improved ICUs, better antibiotics, more aware clinicians. We've done about all we can do in treatment, and we have to move to prevention to make some real difference. Survivors often have deafness and neurologic changes. It's more common in children with their developing brains than it is in adults. It can be very severe. And the case rate has dropped dramatically, significantly, due to the vaccines, particularly Haemophilus influenza B vaccine introduced in 1990 has virtually eliminated invasive Haemophilus influenza infection, and that was predominantly seen in children. Pneumococcal vaccine introduced in 2000 has shown a decline in children in 55%, and in overall, all age groups, a 33% decline. Certainly not all adults have received, or not even the majority of adults have received a pneumococcal vaccine. However, the fact that most people are vaccinated has caused a decreased spread of pneumococcus in the community, so that adults who are not vaccinated have also benefited from these vaccines. And the meningococcal vaccines have an impact in the highly endemic areas, but this is a sporadic condition within the United States, but it is such a severe condition, so rapidly fatal, that meningococcal vaccine is really very important, even here. There are parts of the world where, and times in history when meningococcus has been much more prevalent. So, how does this happen? Well, it starts with colonization of the nasopharynx, and once the organism invades the mucosa, there are the defenses are the adhesins on the bacterial surface, but their abilities are based to adhere is based on the organism itself. Once the organism enters the bloodstream, the capsule protects the organism from the circulating complement. So even if you're not immune, you have complements, you have nonspecific oxidization. However, if it's an encapsulated organism, as pneumococcus, meningococcus, and Haemophilus influenza are, then the capsule is allowing the organism to survive in the bloodstream. Transcellularly, it will invade the meninges often within polymorphonuclear leukocytes that have engulfed the bacteria but not killed it. This causes a disruption of the blood-brain barrier and allows other routes for the bacteria to get into the brain. And once it's in the CSF, there's going to be rapid growth because the CSF is low levels of complement, low levels of immune globulin. In a healthy state, there's almost no protein in CSF. So CSF is a wonderful place where bacteria can thrive. So these are the meninges. You have to think about them from time to time. So what going in, you've got the scalp, and you've got the fibrous tissue underneath the scalp. Then you have the periosteum of the bone and the bone. These are all very important protective things. You can have meningitis from direct inoculation if you've got a skull fracture, for example. Once you get to the firm dura mater, it has two sides to it, the side on the meninges and the side on the periosteum. And then there's the arachnoid membrane, the subarachnoid membrane, and the subarachnoid space, and then the pia, which is directly overlying the brain surface and goes into the sulci. So the area of infection that is in bacteria, in hematogenally spread bacterial meningitis, is in the subarachnoid space, the space between the arachnoid and the pia. And you've seen some normal brains and photos of normal brains, but it is startling to see a photo of someone who's died of bacterial meningitis. The entire surface of the brain may be covered with yellowish pus, and the blood vessels either dilated or thrombosed. Here are some pictures of patients who died. Most likely these patients had actually had the antibiotics actually work, but had died anyway because of the damage and brain swelling that occurred. You can see that on the surface of this brain is swollen. There's purulence there. You can see there are some blood vessels that look like they're thrombosed. There are other blood vessels that look like they're inflamed. And if you look around the blood vessels, you can see that's where the pus layer is the thickest. And this is because of, this is an area where the polymorphonuclear leukocytes are trying to have a beneficial effect, and they may be leaving the blood vessel as well. When the purulence is limited to the basal area, this is a common thing in tuberculosis, and you can see here at the undersurface, the basal surface of the brain is covered with an exudate. And in an extreme example, it's not just a thin covering of pus, but it can be a thick covering of pus as a subdural empyema. And that, like a subdural hematoma, can actually increase pressure on the brain as well, because it will attract lots of protein there, it will attract water, it will swell and cause greater problems for the patient. So at times, this needs to be drained. MRIs can help you. You're certainly not going to help you in diagnosis, but in this MRI, first let's look at the CT. You look at the CT there, you can see that the white, where the arrows are, there are patches of increased white. That is, from the contrast that was given, but increased vascularity there and increased thickness. And you can also see that you can actually see the arachnoid membrane is also lighting up in that area and contrasted to the other side of that head. On the MRI, you can also appreciate the involvement of the meninges, which in this case is actually going all around the brain in that MRI. And in the MRI picture, there's a patient who has some ventricular dilatation as well. So what causes it? Well, from birth to about 3 months of age, the two most likely organisms are actually spread in the immediate neonatal period, the first 7 days of life, from the mother, and these are genital tract organisms. Group B streptococci, depending on geographic areas within the United States, 30 to 50% of women may carry GBS in their vaginal tract, and this can be transmitted to the infant and can cause meningitis and pneumonia and sepsis. E. coli is also clearly, obviously present in the vaginal tract or nearby and can transmit to an infant at birth. And then pneumococcus is also seen in this age group, although this probably shouldn't be quite as black as here. But when we see it in newborns, they seem to have almost no ability to really contain it. So it's remarkably severe. As bad as this can be in any age group, this is a very serious age group for pneumococcus. But group B strep and E. coli are the most important. Interestingly enough, for each of these, there's the early onset, which is highly associated with the mother's genital tract, and there's late onset. And even late onset is after 7 days, and late onset is after 1 month. And through that first 3-month period, they're still at risk for these infections. And they're not always transmitted, they're not always coming from the mother. So in this case, they can come from patients living in the world with other people. They seem to be quite vulnerable during that age group. This is getting to be important because we now can prevent many cases of group B streptococci by treating colonized mothers with antibiotics during labor. This has cut down on early onset, has almost no effect on late onset, indicating that we're still going to need a vaccine for preventing group B strep infections. And then finally, in light type here is listeria, and it's very important organism, but it is rare. This is sometimes associated with the genital tract as well, and can be listeria can be a cause of repeated pregnancy loss in people who are colonized in that area. But for the infant, it can cause a severe meningitis as well. And this is not necessarily restricted to the first 7 days, so the first month or two of life. It's really uncommon, so people don't often think of it, but it's important. And this can also have an environmental effect because outbreaks of listeria usually show up in neonates and older people, and they can be associated with raw milk, for example, and there's always been sort of a link to outbreaks to some of these raw milk dairies in certain locations and so on. So anyway, a little side effect. Moving on from 3 months to 5 years, it's predominantly pneumococcus and meningococcus, and pneumococcus is much, much more likely. Now, with high vaccination rates, this is not seen as much as it used to be, but it is still present. Haemophilus influenza B is hardly ever seen in the U.S. any longer, and in fact, the advent of the vaccination did more than we expected. We expected it would get rid of the invasive diseases, but it also seemed to get rid of colonization. So Haemophilus B is not very much around anymore. However, Haemophilus has other strains that can make capsules, A and C through E. And A has become so common in Canada that the Canadian Department of Health is thinking about vaccines for Haemophilus A. And we have occasionally seen some Haemophilus A. So things are always changing in the microbial world, and we only get little glimpses of it when they start to affect us. And Europe, for example, is now seeing very little Haemophilus B with good vaccination rates, but they're beginning to see Haemophilus C through E. And we see strain replacement with the pneumococcus because now we have vaccines that cover 23 strains of capsular strains, but with strain replacement, new strains coming in, now that colonization is going down for these old strains, we may have to continue to increase our vaccine capabilities. Once you get from 5 years to advanced age, it's going to be pneumococcus and meningococcus. And among elderly people, pneumococcus and listeria. So we have talked about this. Once you've had nasopharyngeal carriage and you breach the nasal membrane, these organisms can all cause pneumonia, emphysema, get into the bloodstream, cause bacteremia, local spread, otitis, and sinusitis. But once it's in the bloodstream, you can see peritoneal disease with these, arthritis and osteomyelitis, and meningitis. So strep pneumo, obviously important. It's in a CSF gram stain. It's going to be encapsulated. You can see here around these diplococci that are purple, there's a little halo. That halo is the transparent capsule. And this is what protects them and makes these organisms virulent. An example here is that this is an infant, 9 days old. He had a brief fever. Fever is uncommon in newborns. He was discharged from the hospital. He was seen in the ED on day of life 7. His urine, CSF, and blood culture were obtained. His fever resolved, but the blood culture grew strep pneumoniae. When he was called back, he had 2 seizures. He developed shock. The spinal fluid was typical for meningitis with high white count, high percentage of polys, low glucose. In this case, it was extremely low, non-detectable even, and a high protein. So that's typical of meningitis. Of a bacterial meningitis with infection that's well developed. In this child on treatment day 2, we had imaging that showed diffuse meningitis with extensive involvement of the meninges, as well as edema and infarction was already seen in the supratentorial area bilaterally. By treatment day 18, the initial abnormal diffusion signal resolved, but now he has encephalomalacia, which is parts of where the brain substances actually dropped out, and you can actually see that quite dramatically on the left side of this MRI. He has cystic changes, he's got volume loss of the brain, and there's also some thin subdural empyemas in the temporal region. It's not shown on this particular slice. So that's the worst of the worst. This was a surviving patient with severe brain damage. Haemophilus influenza. These are pleomorphic gram-negative coccobacilli. You can see also on this picture that they do have capsules. They require heme to grow in culture, which is where Haemophilus comes from, blood-loving Haemophilus. There's nothing to do with influenza. That bacteria was discovered in 1918 during the time of the influenza epidemic, and there were some ideas that this bacteria, which is prevalent in the nasopharynx and so on, might have been responsible for influenza, which was a syndrome that already had the name of influenza. It was known that normal populations in Europe, in the United States, and in Asia as well, showed immunity to type B by the age of 4. So the disease was pretty much restricted to children who were under the age of 4 years of age. Immunity doesn't apply to the non-encapsulated types because they can cause otitis and pneumonia and occasionally cause meningitis. And even in adults, Haemophilus influenza non-typable is considered a major cause of pneumonia. Neisseria meningitidis, gram-negative, non-spore forming, non-acid fast, diplococci. They're diplococci, but the individual organism are not particularly completely round, they're more kidney-shaped. And the invasive strains are groups A, B, C, W135, and Y. And in the spinal fluid, Neisseria has a reputation of being extremely rapidly progressive illnesses. Actually, the mortality rate is lower for Neisseria meningitidis meningitis. Mortality rate is lower than for just meningococcemia, because meningococcemia is an overwhelming bloodstream infection, and people die at that stage from septic shock, and particularly from the fact that this is now a gram-negative, and it has lipopolysaccharide in its cell wall, and this is like their LPS, it's very potent in terms of causing shock. So if you live long enough to develop meningitis with enough clinical signs, then you can be treated and generally do fairly well. But if you catch this and you die very quickly within 12 to 24 hours, then that's the end of the story. You may never have developed meningitis. But one of the things you can see in this picture is how many organisms are associated with polymorphic nuclear leukocytes, so that this can be a way that the organism can spread. So invasive meningococcal disease, this dramatic picture here, I was a senior in high school, contracting meningococcal meningitis was the last thing in my mind. This is before I knew it, I was a teenager fighting for life. This is to sell the meningococcal vaccines, which intake has not necessarily been so great, and they've been targeted at different groups. Targeted, for example, at late adolescents, because late adolescents have two possible things they're going to do. They're going to leave home, they're going to go to places and meet lots of other people in military camps and in college campuses, and there's a lot of spread of organisms that the people who are maybe carrying the organism lived in an area where it was fairly prevalent. They never got sick. They got some immunity, but they can spread it around. So disease was known to spread very much in military camps and in colleges. And in some locations, particularly Britain and Sweden and some areas of the world, like the area of Africa that they call Northern Africa, they call the meningitis belt. They're really talking about meningococcal disease. Meningococcemia is associated with rapid formation of petechia and purpura, and very often results in gangrene and loss. So very young children have the highest incidence, then there's a peak in the young adulthood, and then steady higher incidence in later ages. And here's some pictures of group B strep in the CSF. And we're talking about the differences between early onset and late onset. The other difference between early onset and late onset group B strep meningitis is that group B strep in the newborn, about 2/3 of them have pneumonia or sepsis, and 1/3 have meningitis. There are 3 main serotypes, and the type 3 is the one that has a particular tropism for the meninges that causes meningitis. The late onset is predominantly caused by type 3, and that's, so 90% show up as meningitis, and only 10% showing up as sepsis or sepsis and pneumonia. So we've already talked about maternal screen and test prevents early onset disease, but late onset disease has not been decreased by this practice so far. And E. coli, interestingly enough, not all E. coli are equal when it comes to neonatal meningitis. The E. coli that have the K1 antigen, which also has a tropism for meninges, is the one of all the E. coli that might be in a stool from all different variations that have all different toxin profiles and other things like that that seem very interesting. It's the K1 antigen that is the one that is associated with meningitis. As with the others, we now treat them all with 3rd-generation cephalosporins. So you're thinking about ceftriaxone or ceftazidime, chosen for 2 reasons. One is that in some cases, for example, with pneumococcus, there can be some relative resistance among to penicillins. So we use cephalosporins, but also because of brain penetration. So the earlier, like Keflex is not enough, it doesn't actually penetrate the meninges. So when you go from 1st, 2nd, 3rd, down to 5th-generation cephalosporin, you pick some things up and you lose some things, and those are things that you have to kind of keep in mind in treatment. We don't have any vaccine and no preventive strategies for E. coli, and this is a little bit location specific. There seem to be some areas, I mean, even in the United States, some cities which have not so much GBS and more E. coli, and some cities where it's the other way around. Can affect term infants as well as preterm infants. Listeria, the oddball that's quite rare, is occasional colonizer of the maternal genital tract. Dairy pathogens lead to colonization. It's rare to have meningitis and sepsis. It occurs both infants and the infirm, elderly, and not generally in other people. And in this one, you treat with ampicillin plus either gentamicin or quinolone. Rather difficult to treat. So overall, the clinical picture. Birth to 3 months. Patients are listless. They have low-grade fever. They may have hypothermia. They generally they're not going to tell you they have a headache. They don't generally get stiffness of the neck. This is important because when we look at sick people, we want to know about whether they have neck stiffness. We want to test this out. We don't want to miss meningitis. But it's very difficult to evaluate. So actually the protocols are generally that we're very quick to do spinal taps in febrile children. It's virtually always in protocols that are used in major medical centers, for example. In febrile infants less than 1 month of age, if they come to the hospital, they're likely to get a full sepsis workup, we call it, with a blood culture and a CSF, no matter whether they don't look sick or they look sick. And it doesn't matter what their white counts are. From 1 month to 3 months, we play some games, like what's the CRP like? That's maybe more reliable than what's the procal like, because nobody really knows what procalcitonin means or does. But sometimes those things help, and so on. We frequently do lumbar taps in young children, and that's a little thing you're going to say in your mind when you're seeing febrile people 3 months of age and under. From 3 months to 2 years, they may have fever and vomiting, mental change, but you will not rely on a stiff neck until the child is at least 18 months of age or older. So what you can see is that the patient may be irritated when their neck has to move, like when they have to move from one place to another, or when a mother's holding a child and usual little joggling movements that you do to make them feel better will make the child frown, for example, or something like that, rather than be soothed or satisfied. So stiff neck is not always reliable. Once you're after 2 years, you've got strong neck muscles, you're going to have a stiff neck if you have the full picture of meningitis with fever, vomiting, headache, stiff neck, and mental change of a minor sort, minor confusion, for example, inability to concentrate because the headache is so bad. And older people will tell you this headache associated with meningitis, bacterial or viral, is like nothing they ever had before as a headache. They will say things like, this is a headache more than I could imagine a headache could be. It's not, I've had headaches, I've had migraines. It's more like a vice. It's around the whole head, and it is intense. Once you get to advanced old age, particularly debilitated people, they may be listless, low-grade fever, or hypothermia, and these might be nursing home residents and so on who are at risk for bacterial meningitis. Okay, so you got to recognize it, and we talked about the clinical picture, the signs of sepsis. When meningitis was much more common in pediatrics, every pediatrician knew the signs of sepsis, and we were very quick to think about meningitis. In fact, we always thought about meningitis. We didn't always do spinal taps, but that was our checklist. Because this febrile child who's sitting here not looking all that sick have meningitis, and we would think that, well, how likely, what do we know, and so on. When you're beginning to think about it, think about what you can do rapidly. You can do a CBC chem panel. You can do a spinal tap. You can get cultures of the blood and the CSF. You want to do these things quickly because if you really do find that CSF is abnormal, you would really like to get him on treatment within 1 hour, and that's pretty hard to get all that done in 1 hour. You want to use the antibiotics to cover the likely pathogens, so broad coverage first. narrow later. This is a thing you're going to learn over and over again with antibiotic stewardship. Nobody should ever yell at you for giving every antibiotic in the book to a really sick person, as long as you're going to reevaluate that 2 or 3 days later when you actually have some real data. So, a little bit of restraint is often good. You don't always have to give meropenem to everybody, but this can cross your mind, and you should never just hold your head up if someone ever decides to scold you for it, because it's ridiculous. Okay, so high-dose steroid treatment in bacterial meningitis is said to be treatment beneficial. It has never really been proven in children, and it's not all that clear that it really is. However, it's often used, but it's not sort of like de rigueur. I think that it's getting to be, you better do it if you're treating adults, because you want to improve these people's outlook. We talked about, you get the antibiotics in fast. When you analyze the CSF, this is really important. You're going to want to look for red cells. This can be as a result of trauma during the tap, but it can also be due to the fact that there may be hemorrhage going on as well. You're going to count the white count, the differential. Bacterial meningitis, when it's well established, will have a white count, will have a polymorphonuclear predominance of over 85%, usually over 90%. And there'll be very few monos and very few lymphocytes as well. Early, you catch someone with an early headache, there's not much going on, they haven't been sick very long, maybe they've had a rapid progressing condition. They may have even no white cells. We just discharged a child with late onset group B strep meningitis whose first spinal tap, she was over 1 month, she had a spinal tap and a blood culture. Her blood culture was negative, but her spinal tap grew out slowly 3 days later, and she had no white cells in her spinal fluid. So she was sent home after that spinal tap looked like it was normal. However, she has had a rocky course by the time she was brought back in. She was given 1 dose of ceftriaxone, but she would have been given, ceftriaxone more frequently had she been admitted and had to be waited to call back 2 days later. So even sometimes culture everything. And the other thing you can do that they didn't do in this case, they thought the spinal fluid was so benign they didn't send it for the multiplex PCR, which actually, when this child came back, we sent the spinal fluid, and the multiplex PCR did show group B strep in PCR positive in that. So there's might be even nothing so evaluating the spinal fluid is something you're going to learn to do, but it's not the end-all and be-all. And then in the hospital, my feeling is that it's likely to be bacterial meningitis. Most patients should be watched very, very closely, possibly or probably in an ICU. You're watching for signs of shock, increased intracranial pressure, neurologic change. Secondary survey for sites of infection elsewhere. They may, during the time that their brain was colonized, their joints may have been colonized. Sometimes people show up with, joint is also a sort of protected place, so bacteria can stay in there for a few days and then start to cause trouble. You can get some bacterial arthritis, for example, and look at the comorbidities that the patient has. And then every patient should have some formal evaluation of their state of health, their capabilities neurologically, their hearing, which is one of the first things to go in terms of deficits after meningitis, and some kind of a cognitive assessment. It's not fair for people who've had this potentially brain-damaging illness to have sort of brain fog and little things that are not, I'm not just doing so well as I used to do. Somebody's really got to be thinking about that in a real fashion and a way to help them. And this, you certainly want, in the development of young infants, you certainly want to see that their development is going to be carefully monitored, not sort of set aside, oh, he didn't walk at a certain time, well, Einstein didn't walk, or he's slow to talk, any deviation from normal is important in someone who's had bacterial meningitis. Okay, so CSF. Up to 10 plus minus 5 is normal. However, for encephalitis, they say more than 5 is a sign of pleocytosis. In bacterial meningitis, you can see 0 to several thousand. Tuberculous meningitis, you can see greater than 20 to several hundred. Tuberculous meningitis develops slowly. People usually have symptoms for about 2 weeks before they come to attention. And so they usually have some pleocytosis. Usually even well established, it is not as, doesn't call up as many white cells as a bacterial meningitis. And viral aseptic meningitis, usually 20 to 1,000, but it can be higher. You can't really distinguish. There's not rare at all to see a viral meningitis with a white count of 5,000, for example, which you would say, well, that must be bacterial, but it doesn't. That's not necessarily true. It is a differential that helps you. With bacterial meningitis, you're going to see polys predominant almost throughout the course, and that will stay there for at least 10 to 15 days. Even with treatment and a good outlook. Tuberculous meningitis, they're overwhelmingly mononuclear cells. And viral meningitis, interestingly, early on, the first day to 2 of symptoms, polys predominate, but this switch occurs within about 24 to 48 hours to a lymphocytic predominance. So it's one of the things that's going to drive you crazy. Protein is usually elevated in bacterial and tuberculous meningitis when it's well established, but it's usually normal in viral meningitis. And the sugar is low in bacterial and tuberculous meningitis, quite low, less than 2/3 of the bacterial, of the blood sugar. And it's normal and over 45 in viral meningitis. 40 and 45 are the numbers to remember there. Special forms. Well, if you have medical hardware, CSF shunts, drains, skull and spine nuts and bolts, you're likely to get infected with Staph coag negative, Staph aureus, group A strep, and enterics, not the classical meningitis organisms. If you have direct inoculation into your brain or spine, obviously it's going to come from the source, soil and water organisms, enterics, skin flora, Staph aureus and Staph epidermidis, and then anatomic abnormalities. Midline dermal sinuses or fracture of the cribriform plate. So if you see someone with recurrent meningitis, there's a possibility that they have abnormal entry into the spinal canal. So actually for all patients, you should look around their back down to their gluteal cleft to see if there is a little pimple or it's a sinus that's showing up there. That is actually a place where bacteria can get through, and you might have enterics as well as common bacterial organisms. If people have been in car accidents and had head trauma, that plate, the cribriform plate that separates your nasal canal from your skull is fractured. There's a way for direct inoculation. So recurrent pneumococcal meningitis, for example, there may be an anatomic abnormality that leads directly into the cranial vault. Okay. Tuberculous meningitis. We still see this in Hawaii, and Hawaii is still the leading state for tuberculosis across the United States in terms of incidence. It shows up slowly with headache, vomiting, and progressive lethargy. By the time it occurs, there's usually quite severe increased intracranial pressure. There's usually evidence of TB elsewhere, but well tolerated, for example, pulmonary tuberculosis. It's very prominent to have basilar meningitis, and we saw a picture of the brain cut out with basilar meningitis. And here is a CAT scan where you can see this slice along the here. That contrast is basilar meningitis. Complications are increased intracranial pressure, and hydrocephalus is really quite common, and tuberculomas or tuberculous abscesses within the brain substance. The people who are at increased risk are the children, the aged, and the immunocompromised. Brain abscess. This occurs hematogenously when you have bacteremia or endocarditis, for example, and if you have a cardiac abnormality that causes a right to left intracardiac shunt, so that you take organisms that don't go through the lung, which is kind of like a filter out of organisms, but go directly to the bloodstream from, say, a bad tooth or something like that. You can get brain abscesses, and any bloodborne pathogen can show up in the brain. This is a postmortem slice from showing 2 brain abscesses. They can be well walled off with an enhancing rim that you can see in living patients on imaging. Epidural abscesses can occur particularly after frontal sinusitis. The frontal sinus is very, very thin bone walls, and so any swelling within that can cause rupture forward, causing a tumor or a swelling, and rupture backward into the cranial vault and causing an epidural abscess, which can spread through the meninges to the brain substance as well. And mastoiditis, so oral and ear organisms are likely in epidural abscesses. And spinal epidural abscesses can occur associated with osteomyelitis of the vertebrae, and staph and group A strep predominate, and they can cause symptoms by the pressure that they can cause within the bony spaces surrounding the spinal cord. Fungal meningitis, Candida, not so rare in infants and immunocompromised, particularly in cancer patients. Disseminates to other organisms, especially the skin. So just like in meningococcal disease, where you may see bruises and petechiae on the skin, the Candida can show up as with this sort of purple rash. It often follows antibiotic use in immunocompromised patients who are treated for one infection. They can lead to Candida bacteremia and Candida meningitis. We do have antifungal therapy available, and it can be quite effective. Cryptococcus. We also can see this in Hawaii in normal people as well as immunocompromised people, associated with contact with bird droppings, and antifungal treatment is available. Last patient I saw with this was a boy who had a best friend he often stayed over at the best friend's house. The best friend had a parrot. He was immunocompromised. He got cryptococcus from just from the nights he spent sleepovers with his friend. And then coccidioides immitis, valley fever. It's geographically limited to the American Southwest, predominantly California and Arizona, predominantly in the agricultural areas, very much more common among the agricultural workers. There also seems to be a racial and genetic link to susceptibility and severity associated with cocci. And this can be pulmonary, but it can also cause meningitis. Cocci meningitis is very difficult to treat. People can live with it for long years, but may need to have antifungal treatment and even a reservoir to allow antibiotic instillation directly into the brain in the treatment of cocci. So if you were practicing in California, you would know a lot about cocci. Okay, so time for discussion, and also bio-break. So what do any of you know about meningitis? And had any experiences with it? Are there any questions that have been raised by? This is going to be on your mind when you deal with febrile patients. And it should be on your mind when you deal with febrile patients. It doesn't mean you're going to be, going around with a needle and jabbing it into every person, but you're going to be asking yourself about, how serious is this infection? Where is it likely to be? What clues do I see here? So that you can make an early diagnosis and do your best to improve the situation. You have to understand that we have not really changed the trajectory once we had good antibiotic therapy and decent, decent doctors who recognized and treated quickly. So if we continue to have decreased immunization, we are going to see more and more things like pneumococcal meningitis, which can be very devastating in every age group. One of the things that when Haemophilus influenza was so common among children, dominated our thinking, oh, this is what the model meningitis is. But the model meningitis is actually pneumococcus, and it is far more severe, far more likely to lead to thick covering of the brain, what we call pachymeningitis, far more likely to lead to adverse outcome, especially in children, but also in older people. I think that's really the one to keep, currently the one to keep in mind. So I hope you're getting some feeling about, how to move when you think about these things. I mean, if you start thinking about this, you can bring it up to when next year you're going to be third-year students, you're going to have supervisors. You can bring it up to the supervisors. Don't be shy about it. You thought about it. Well, this man has a headache. How do I know he doesn't have meningitis? And you can go over then with them why he may have headache, for other reasons, But that's the turn-up. Yes, people fever and headache. Well, how bad is the headache? A few things like that start to come in. And people will always they're not necessarily even errors. I think the case I told you about the child with group B strep meningitis who came to the hospital appropriate when she had a fever, had a workup. The workup looked like it was benign. They gave a dose of ceftriaxone, which would hang around for another day, but unfortunately, it didn't send for a tool that we have, which is PCR panel, and I think that's probably reasonable. Probably most people wouldn't have sent for that, but when it slowly grew, and we got the call that it was growing, the child already had, some maybe more damage than she would have had otherwise. Okay, so if you want to take 5 minutes, then we'll come and we'll talk about. One of the things that's great about this is that we have learned a lot about how to treat meningitis. We've learned how to recognize it. We talk about viral meningitis, which is actually fairly common. But once we get to talking about encephalitis, we're going to definitely have more areas that are unknown. So I hope you'll all come back so we can talk about this area, which is definitely evolving and not super well covered so far.
It does kind of look like that's sure.
Like I tried looking at the folder, it's not in the
I'm like trying to be better. Yeah, okay.
Oh my god, this time it was her.
like this. It's actually just
Not too helpful.
what are those cookies? Those not brown crackers. Biscoff. Biscoff.
I thought it was really.
I don't want to get
They're just like
You could do a look.
I have to go into this.
Yeah, and I'm gonna go.
Actually, let me just right now. Open cereal whatever next door. Right now,
And we're gonna have to shave your head.
Have you heard of
And we're gonna pay like
So that's okay with you, right? There's no problem. She's like, I don't have any questions.
It's really like non-invasive.
I'm trying to full name. It's not on there.
we tried and still it's quite wrong. Doesn't make sense to me.
Why did they switch? I can see it.
Everything except for my So if it's plastic, that's not fine, right?
It was like, I don't know any of the
Stiff glue something.
I think it's like the only thing that I did with stiff for is like maybe if you're feeling that. And then he was like, yeah, because other than that, I can't tell you anything.
Give these cards. Oh, you're in the first round. Okay, though. I just put that out before the game, just like straight jacket and just screaming.
I said, hey guys, what do you want from this? They said anything. So I was like,
If your mind gosh. I thought that ties out. No, I don't wanna. What's the have you had? No, I just wanna rise. You're like, I have
too late, bro.
Okay.
And they're all units.
Okay.
Hospital.
Yeah, she's covered because she's
It's just nothing to lie around.
It's 6 morning.
I told her
Drink some water and take a nap. I am having one. So I'm look at it. I've thought of it,
Yes.
you could do like a journal. Yeah, I still think I would like this. Honestly, I didn't.
show up that much.
Yeah.
So like it's not crazy.
My friends are here like. No, well, let's talk after this lecture. Yeah. Look at our schedule.
That's even better, right?
Right?
I don't know about that one.
Less heavy. Yeah. I like red is a little bit more.
Yeah, for sure. Red is more warm.
Don't do it.
Mine's not gonna look like Caitlin's
Some of us
brow.
have red hair.
Mine's not
Mom.
gonna look like Caitlin's.
I think it also you can like mix purple and stuff.
Extra work for us. Feel me.
Okay.
If I do it at all, I have to use it
No, when I was in, it was
in your brain.
I did.
So if it's in your brain, if bacteria are in your body, right in the area
Wait, yeah, that one's like bigger probably the sun. She makes me so happy.
It's like
You're not putting your eyes
go out at night and
I don't think anybody is surprised by me.
Like honestly, in advance of
very few of us. Very few of us actually get serious. I still don't have antibody to
You're like,
not at risk. Okay, everybody. So a good question was about what about highly contagious things like meningococcus? The close contacts of highly contagious conditions like meningococcus should be offered antibiotic prophylaxis. And this is usually in the form of a shot of ceftriaxone. And in Hawaii, for example, if we had a patient with meningococcemia and called the health department, they would actually be sending people out that night to give shots to the immediate family. But we would not be saying, oh, something or other high schools should all be tested or treated or anything like that. It's the close contacts in family type situations where things, or dorms or military. In fact, one of the reasons why the meningococcal vaccine was developed was because of the serious problem that happened in the military among recruits, coming into new duty stations and so on. So we now have vaccines against meningococcus. So now we're going to start with viral meningitis or aseptic meningitis, relating this to encephalitis later because it's also the same organisms can cause encephalitis. So viral meningitis can present with fever, headache, vomiting, stiff neck, photophobia, and minor mental changes like irritability and irascibility, listlessness, etc. All age groups, especially common in newborns, and not necessarily newborns in intensive care, but newborns, free-living newborns coming in with fever, they may have this mild aseptic meningitis. Most common causes are the enteroviruses, and these are major causes of encephalitis as well. Include others in all age groups: mumps, varicella, chickenpox, influenza can have an aseptic meningitis, and lymphocytic chorial meningitis virus, very, very rare. The enteroviruses are frequently epidemic, and so some years there's epidemics of enteroviruses, and they're more prevalent in summer, even here in Hawaii. But they are seen in Hawaii all calendar months. We don't have strong seasons here. You can have a rash with an enteroviral meningitis. One of the things enteroviruses do is cause exanthems or rashes, but very often you don't. So the sepsis-like picture of serious illness is uncommon with a viral meningitis. It's more of severe headache. You're looking at a person whose blood pressure is still good. They're not on the verge of shock. It will resolve in itself in 3 to 10 days, generally with a self-limited course. A very good prognosis neurologically, despite the severe headache. These enteroviruses are very huge number. Coxsackie A and B echoviruses. The later discoveries just stop naming them after the towns where they were first found or somebody's idea, but now they're numbered. They are single-strand positive sense RNA viruses. They're very small, and they also include the paraechoviruses, which track very much with the enteroviruses, polioviruses. So poliovirus has a neurotropism. Rhinovirus, very common virus with a common cold. They're also in the picornavirus family. And oddball here is hepatitis A. They have the capacity to survive passage through the stomach. They can survive on surfaces, so they can spread that way as well. A high proportion of people, and they use different receptors that leads to different outcomes. For example, the poliovirus has a poliovirus receptor on cells so that they can actually track the poliovirus. Now poliovirus is largely a thing of the past because of a vaccination, but we don't know how long that will last. High proportion of these infections are asymptomatic. So enteroviruses spread through a community widely. Most people who have them aren't sick at all, so it's kind of sporadic, a sick person here, a sick person there. But in the summer, there might be a time when there's really quite a lot of people, high absenteeism and so on, and some will have aseptic meningitis. We can diagnose it by PCR. For encephalitis, we frequently are trying to find the cause and use the PCR for enterovirus. So virus shedding occurs for a long time after infection, and so on. So these are just things you really need to understand about enteroviruses. They are both endemic and epidemic. There's a lot of clinical conditions other than meningitis and encephalitis that they cause. Fever without other focus, rash disease, and so on. The pathogenesis is complicated. It goes through both a minor and a major viremia stage in people who are significantly infected. As soon as antibody appears, soon after that, the viremia diminishes and the virus titer falls. Symptom duration can be as long as 5 to 14 days in the first infection. And many clinical findings due to enteroviruses. So whenever we think fever, we are always thinking about enteroviruses as a possibility. So most common is asymptomatic and then fever with no other findings. This is the fever that you have for several days and finally it goes away when you make antibody. And how could it be going on for so long? And it could go on for that, long 7, 10 days and so on. That's why we don't usually go crazy to work up people who are otherwise not very ill but have had fever for 10 to 14 days, because jumping too quickly and evaluating them unless they have some outstanding symptom means that you're just going to spend a lot of money and they're probably going to get better by themselves. But this is very much a difficult thing to deal with. So if you have fever and a rash, especially so-called hand, foot, mouth disease, you would like to think about enteroviruses. Pharyngitis, in the summertime when there's a lot of enterovirus circulating, you see a lot of people with non-streptococcal pharyngitis, a painful pharyngitis with swollen tonsils and exudate or ulcers in the mouth. myocarditis, pericarditis, then now we're into where you get to encephalitis. It's pretty low on the list in terms of prevalence, but it is still there. And finally, the very rare one is that, remember, enteroviruses are related to polioviruses. Polioviruses are enteroviruses, and there is now a type of acute flaccid paralysis that occurs particularly in the US with enterovirus D68, and in Asia with enterovirus 71, and it's a polio-like illness. So this is what you might see in the throat of somebody who has enteroviral illness. They may or may not have meningitis, but that's what it might look like. So I'm not going to talk very much more about that, but we understand the pathogenesis of the meningitis pretty well. The clinical signs are pretty similar. You're going to diagnose it by a lumbar puncture. If you need to start antibiotic therapy, you're going to direct it against bacteria, possibly tuberculous or fungal, but we don't have any antivirals that are effective against enteroviruses or most causes of aseptic meningitis. It's generally benign and self-limited, however much the headache is severe and the patients feel quite ill in the very beginning. But occasionally encephalitis and polio-like flaccid myelitis. So this is when we get to encephalitis that is a mystery. So you have definite abnormalities in the brain function, and they can be wide: motor, sensory, altered behavior, recurrent seizures, frequent seizures, personality changes, speech and movement disorders, usually with fever and systemic signs of infection. But the distinction can be blurred. You can have meningoencephalitis we talked about, and then abnormal brain function in association with other processes is called an encephalopathy. Like you did not find a virus to cause this. You didn't find any cause, but the person has changes in their mentation. In this case, you would think about things like poisoning, drug overdoses, degenerative diseases, and there is something called toxic encephalopathy. And you would say, oh yeah, that just means they just drug or something like that, or poisoning. But actually, that term is usually meaning we're never going to find the cause. Somebody comes in, they may have something severe enough in their brain function that they actually die of it. We never find a cause. We eliminated almost everything else. So when you see that toxic, it might be you should be thinking about drugs or poisonings, but it might also be that somebody's talking about, it's just a bad term, but it's out there. So we don't usually find a cause. People who present with markedly abnormal changes in their brain function. We can find direct infection about 20%. And here we're usually thinking of herpes simplex, which is the prototype. This has an extremely poor prognosis without any treatment. We do now have effective antivirals, which have made a great change, but you still can have severe damage due to herpes simplex. The other viruses, enteroviruses particularly common, are viruses. There was a pretty important study done in the late 90s, early 2000s called the California Encephalitis Project, where a great deal of money was spent to do up-to-date viral work on patients with encephalitis. They had about less than 400 patients in their study, and they found definite proof of a virus in less than 20%. But when they had added the probable cases, the ones they could diagnose by serology, showing us seroconversion, they were able to get it up to about 20%. Now we have new tools, and actually we have a patient in the hospital now who either has a psychological problem, probably a depression with some hysterical features, or has encephalitis. We have found a virus in his we have found viral DNA in his blood, and we now have the ability to find viral DNA or pathogen DNA in the spinal fluid via metagenomic testing. And that test is out. While I'm talking here, I should be at a meeting about, well, should this patient go to a treatment center, psychiatric treatment center, or does this patient's illness, is it encephalitis? Because he has characteristics of poor brain functioning, of psychological and emotional changes, as well as seizures and some abnormalities on the EEG. Autoimmune etiology is at least 20% and probably much more. This can be two types. Specific antibodies directed at a host antigen in the brain. And the most common one of these is NMDAR, which is antibody directed at the NMD receptor. There's a growing list of other autoantibodies. These can be sent for and detected at a specific research laboratories. And so we're now finding more and more of this autoimmune. There's also another less specific form, and lupus erythematous cerebritis, which is a multi-antibody attack on the central nervous system. So lupus encephalitis is also an autoimmune etiology, but without the finding of a direct antibody directed at a brain antigen. And so when you're thinking about an autoimmune etiology, particularly likely to have this psychological overview or psychiatric symptoms. Think about autoimmune disease. You can test for it, and actually you can treat it. You can also test for lupus, and you can treat it. And so these are important causes of encephalitis that you can diagnose and treat. Then there's a substantial fraction that are autoinflammatory that occur in a person who'd had a prior infection or a particular immune stimulus, and sometimes that is a vaccine that can stimulate an inflammatory response that's directed at neural tissues. And we'll talk more about that with some examples. And then finally, fungal infections actually go beyond the meningitis and cause encephalitis or involve another brain substance. Parasites locally, angiostrongylus or the rat lungworm, and amoeba, a rare cause of severe and usually fatal encephalitis. And the slow viruses, scrapie, Creutzfeldt-Jakob disease, and measles, subacute sclerosing panencephalitis, which occurs several years after the measles infection in a very minor percentage of patients. So viral, we talked about herpes simplex being the prototype, talked about most of these agents already. Also thinking about the arboviruses or the mosquito-borne viruses. West Nile is now seen across the entire United States. No one understands why it hasn't gotten to Hawaii yet, but it's an important cause of viral encephalitis. Yellow fever, historically famous in the United States and now resurgent in South and Central America, a likely threat to us. We have all the same mosquitoes that can transmit it. Zika, we have seen Zika in the Pacific Basin. Eastern and equine encephalitis are mosquito-borne, so are lacrosse, California, Powassan. Lacrosse, California, and Powassan are generally upper Midwest viruses. And dengue, we've had our own dengue outbreak involving something like 400 patients about 7 years ago. So and dengue was endemic in Hawaii prior to 1945. Rabies, of course, is a virus. Retrovirus is HIV, and TLV cause encephalitis as well. We have a lot of tools now. We have CSF multiplex panels that will help us make diagnosis. We can do individual PCRs for many of these agents. We can do viral culture, but that's more difficult and less available, probably because we have so much better tools with the PCR and serology and the growing field of metagenomics with ability to detect non-human DNA in clinical specimens such as blood, spinal fluid, and other body fluids. And then we also use the MRI to make diagnosis etiologically, and I'll show you how in a moment. So looking at the herpes viruses, to remember the herpes virus group is one of the most interesting groups of viruses. It is the largest human virus, and this is double-stranded DNA virus, has the ability to get into cells by rolling past cell surfaces and the process of tethering and patching to receptors and invaginating enters the cell. We have antiviral drugs for many of these, but we only have one vaccine that is for varicella. There's a complex replication and virion assembly in the nucleus, and the fascinating business about latency and reoccurrence relates to changes in the DNA, whether it's linear or circular. So once you get a herpes virus, you will always have that virus within you. And we do have antiviral drugs because we can target DNA replication. These are examples of herpes simplex encephalitis. Left untreated, it will progress to almost certain death and has tremendous ability to affect the temporal lobes. So you can detect temporal lobe involvement if there are seizures by EEG localization, by CAT scan, and you can see in this CT with an associated brain how bilateral temporal lobe involvement can look like. And here is a slice of a brain where there's been actual necrosis and dropout of most of the temporal lobe that happened before death. Other examples in living patients of herpes simplex encephalitis. If you saw this on a MRI involving almost exclusively the temporal lobes with some spread outside of the temporal lobe unilaterally on one side, then you might say, hey, I suspect herpes virus. So you might even make the etiologic diagnosis from the picture because of the temporal lobe involvement. And they may have temporal lobe is the focus for the seizures they may have associated with it. So there's some focal findings there as well. So we've talked about enteroviruses and herpes simplex, and now that we have a new tool, and that is the metagenomic tool looking at the CSF, we are looking for other things, and we have now a parvovirus under suspicion. And I found that in the last den, I'd never heard of that, parvovirus causing encephalitis, but this patient that I talked to you about who may or may not be having a psychological problem as his whole source for his disease, or may have encephalitis that is contributing to his psychological distress. Parvovirus has now been recognized since about 2015 as likely proven cause of encephalitis in a small number of patients. There will be more viruses that we'll find. But we're looking now at the autoimmune etiology. The best known autoantibody, as I mentioned, is the NMDAR. And that, I always forget what it stands for. Spelled out here, I will get it in one more minute. N-methyl D-aspartase receptor antibody. it may be idiopathic. It seems to occur in children and adults, but it can be tumor related. And this is now called a paraneoplastic problem, that especially ovarian tumors are involved. The clinical presentation is varied and very bizarre. Patients have motor symptoms, they have aggression, particularly paranoia, seizures. They progress to somnolence, cognitive loss, and coma. If you find a tumor, and when we see someone that we diagnose with NMDAR, we will look for tumors. But when you find a tumor, if you remove the tumor, the problem will go away. The antibody ceases to be formed. The stimulus from the tumor to make it form is gone, and that can be curative. Otherwise, we've been treating with anti-inflammatory therapy, high-dose gamma globulin, plasmapheresis, and often all three of those. But we have found more recently that B-cell suppression with the monoclonal antibody rituximab will decrease the antibody production. It also will decrease the B cells able to make new antibodies for this patient. So you are giving this patient a certain severe immunologic problem, potentially. And as I mentioned, there's a lot of new autoantibodies, and they can also be treated with rituximab, which is very gratifying to take a patient who has this very severe illness that can go on for a long time. A patient of mine had an 11-month hospitalization before we got control of an MDAR. And now we can make a diagnosis of an antibody, and we can suppress the antibody. Giving gamma globulin in high dose will suppress the antibody because sort of a negative feedback, antibody making machinery gets turned off if they can detect that there's too many antibodies around. But that's a pretty gross tool compared with just knocking out the B cells for a period of time and trying to protect the patient during the period when they don't have any B cells. So we have diagnostic panels. So here's the example. An 11-year-old girl wrote in because she was acting weird. It started when she said she was hungry, but when she was given food, she gagged. The next day, she was very agitated with a lot of increased physical movement. She had trouble finding words. She was going over and over again in a paranoid way about an old grievance. And her behavior was so disturbing to the family. And they also found that she was acting somewhat mean to her siblings, that they brought her to the emergency department. But nothing was found, and she was sent home. The next 3 days, she continued to have gagging with eating. She felt weak. She couldn't sleep. She was talking, laughing for no reason, moving more. She exaggerating. She was accusing people of things. But she didn't notice that she was acting weird. They asked her, what the hell is going on? She didn't notice. She had a lot of time daydreaming. She was again seen in the emergency department. And really, she had no physical findings, and she was discharged. But she progressed from being from these psychological symptoms and this increased motor to the fact that she couldn't walk because her feet dragged. She was unable to sleep. She had night sweats. She was not feverish, but she was still gagging. She lost weight. Sometimes she couldn't talk at all, but she could write. When she was seen in the by her doctor's office, she had rapid heart rate, so he sent her to the ED for a third visit. By the time she got there, her heart rate had slowed down. A workup was pretty negative, but a spinal tap showed that she did have 10 white blood cells. They were 98% lymphocytes. She had a markedly elevated protein. And for several days, we sent for oligoclonal bands, which is a way of looking, sort of a gross way of looking for antibody. So she had antibody in the CSF. Imaging of her head, MR spine, and normal. Her MR of the brain showed a flare signal in the frontal lobes with meningeal enhancement, suspicious for meningitis. After she got transferred, she was awake, alert, no acute distress, but repeatedly rocking her upper body and wiggling, emotionally labile. And then in the middle of a nice conversation, she would get angry without any obvious reason. So a lot of confusing things go on in somebody in this situation. So in the hospital, of course, she had periodic agitation, fevers, tachycardia, restless nights where she couldn't stop moving, hallucinations, facial twitches, mouth movements. She progressed in being unable to speak. She was unresponsive to commands. But her CSF was positive for NMDAR antibody. Steroids and IVIG, she continued to deteriorate. She ranged between semi-coma and agitation. She had seizures that were unresponsive to medications. She was started on rituximab from day 10. In the hospital, and this was repeated on day 17. And she was monitored with weekly CD20 to confirm that she had depleted, that's a marker for B cells, completed her depletion of B cells. And on the 11th day, from starting rituximab, she had increased periods of calm with limited random movements compared with the past. She was able to make some hand signs, but she still had a lot of tremors, so it was hard for her to communicate that way. She could follow commands, and she could say 1 to 2 words if you waited time, allow her time to do. So this was a dramatic change once she were able to suppress the production of the antibodies. She made a full recovery by 6 weeks on rituximab therapy. Before we had that ability, I had that child in the hospital for 11 months who actually ultimately did recover. So this is NMDAR. It's really on the, if you were to say, clinical medicine and psychiatric medicine, it's right on the verge. There is a lot of things in the early stage that show that the brain is involved in complex ways and reacts in complex ways. So these are the examples of a recent publication on NMDAR. 80% had seizures at some point. 90% had psychiatric symptoms. Sleep disorder was common. Movement disorder was seen in about 75%. Cognitive problems were seen in most. Altered consciousness was seen in most. And odd difficulty controlling heart rate and blood pressure was seen in about 35%. Interestingly, this is the one that can be paraneoplastic. And when you look at, this is very complicated, but what they're trying to tell you is that when you look at children between 8 and 11, the finding of a tumor is very uncommon. And the red color is females with a tumor. When you get into adolescence, it goes higher. And when you get into young adults, 24 to 25, the number of women who have a tumor, almost always ovarian, becomes dominant compared with people who have NMDAR disease without it. And that frequency does go down as time goes on. Unfortunately, this can be a recurrent disease. Once you've had this, about 20% have a recurrence. Less likely to have a recurrence if you had the tumor and had the tumor removed than if you had no recurrence. So, and this is just an example that on the modified Rankin scale, which is used for assessment after stroke. But if you apply it to NMDAR, find that 85% of the people who have NMDAR encephalitis at the time this paper was written got down to the severe disability level, which is bedridden, incontinent, and requiring constant nursing care and attention. So the swing is from some sort of a prodrome, weird behavior at home. It can be much longer than 1 week. And then 1 to 2 weeks of the definite things. Then hit the nadir with neurologic complications, movement abnormalities, dysautonomia. And then with treatment or time or our previous treatments, a lot of gamma globulin, repeated plasmapheresis to remove antibodies, we could get people who recovered and may have some deficits months to years later. Now, one more category to remember in autoinflammatory. And this is often an infectious trigger or a post-vaccination trigger. You can see this following a period of an illness or a vaccination, particularly common after mumps and varicella. So chickenpox and mumps, and many other childhood illnesses, including enteroviral illnesses. It's a focal inflammatory response rather than a direct active infection. They're not infected any longer. The onset is usually 2 weeks to a month after some sort of a minor illness or some sort of immunologic encounter like a vaccine. This results in ADEM, acute demyelinating encephalomyelitis. And this term, unfortunately, like all abbreviations, is bandied about. You know, in medicine, people will say, well, I think it's ADEM. And you say, what the hell? There probably could be 10 abbreviations that could be ADEM. But unfortunately, I have a hard time remembering this means A, acute, D for demyelinating encephalomyelitis. I mean, wasn't just ADE, for heaven's sakes. Anyway, that's a problem. So unfortunately, when you are on the wards, you know, you're going to hear somebody say, oh, I think this is ADEM. And you're going to look around and the interns will know what ADEM is and the attendings will know what ADEM is. But then you get to a different service and ADEM means something else or something like that. So anyway, you'll have to live with that. I'm sorry. I wish we were always good about writing the damn thing out. It would help certain people like me. But anyway, you can make this diagnosis on the CAT scan or the MRI because it's going to show you scattered multifocal white matter lesions in the CNS. Another autoinflammatory encephalomyelitis is Guillain-Barré syndrome, which is known to follow certain fairly large number of infections, common ones as well, that results in lesions in the anterior horn cells of the spinal cord. Once again, a myelinating area. Can also be seen in MIS-C following COVID. And in this case, the therapy is anti-inflammatory rather than antimicrobial. Corticosteroids, antibodies to inflammatory cytokines, or immunosuppression. So an example is a 5-year-old boy with 4 days of fever, headache, and vomiting. Now he's lethargic, he's confused, and he has bilateral leg weakness. He's still got a fever. He's got a fever now. His pulse is 120, so that's elevated. His respiration is 28. Oxygen saturation is decreased. He's semi-conscious. He's occasionally moving his arms. His respirations are shallow. He isn't working hard to breathe. In fact, he's hypoxic because he's not breathing well enough. Has clear lungs, regular heart rate. His abdomen's unremarkable. He opens his eyes when his blood is drawn, but he didn't struggle or cry. His legs are limp and he has no reflexes. So, what do you do with someone like this? Doesn't sound so bad when you hear, go see this kid with 4 days of fever, headache, and now he says his legs are weak. But well, you're going to get help because this is a serious problem. He is he's getting hypoxic, and he also has no reflexes, and clearly he's mentally not all there. So CBC is unremarkable, metabolic panel is normal, blood culture was sent. CSF is abnormal. He has 10% neutrophils, 80% lymphs and monos, markedly increased protein. His multiplex PCR is negative for pathogens. But what next is, there's his MRI. And he has these scattered multifocal lesions that show up in white in the areas where there's myelinating tissue or in the junction areas between white matter and gray matter. And in this case, the spinal cord was also involved, leading to his paralysis. So he has this deep white matter lesions plus inflammation in the spinal cord. And this is ADEM, and the radiologist will make that. And so about this interesting case, you run down to radiology, and the radiologist will say, well, I think it's ADEM. Anyway, that's ADEM. So treatment is more common in children than adults, but clinically quite similar, whoever gets it. And it can occur after vaccines, as I mentioned, so that's one reason why adults may get it. 1/3 to 2/3 can have oligoclonal bands. Once again, you're looking for proteins in the spinal fluid, and myelin, oligodendrocyte lipoprotein, MOG antibodies in the spinal fluid. Interestingly enough, you hospitalize them for 1 to 2 weeks with fair to good ultimate neurologic recovery, and usually treat with steroid therapy, IVIG, and sometimes nonspecific immunosuppressive therapies such as corticosteroids. But actually has a fairly good prognosis. It's a pretty can be a pretty amazing condition. It isn't so rare. So I really hate to do this, but this is the other 50%. What do you do when you are confronted with somebody who has a confusing picture with serious involvement of their brain and likely long hospitalization and a very frantic family and a patient who may or may not be aware that something is really serious gone in his head. But these are some suggestions of the profiles and the possible causes. And still, when you consider a list like this, and this is just really here for a reference, but when you consider a list like this, you realize that this is really a very very broad area that needs a great deal of simplification and sort of synopsis to be able to deal with various possible viral causes, non-infectious causes, other non-infectious causes such as lymphomas or cancers, autoinflammatory diseases such as lupus and other collagen vascular type diseases. So encephalitis is very hard. It's very bizarre, and it's very, very challenging. But it's there, and we are getting new tools all the time. So I did have a very interesting patient to tell you about that you may or may not be very interested in, but I was. And this was an adolescent girl who had an MDAR. She had been an excellent student through elementary and middle school. But when she got to high school, her grades deteriorated badly, and the teachers thought that she was in need of special education, which was a super shock to her parents. This happened in first semester. But over Thanksgiving weekend, she went to a sleepover and had a severe episode of very strange behavior culminating in a seizure, and she was admitted to the hospital for that. By that time, we were kind of early adopters of NMDAR serology. We had so many patients for a period of time that instead of sending it to the reference lab, we had our lab develop the test and turn it into a CLIA certified test so we could actually use it in patients. And so we did diagnose her fairly quickly, and we were sort of leaning toward this because some of the stories they told about the weird way she had been behaving compared with her prior life and some of the psychological aspects of it. Although she didn't have the restless leg sort of phenomenon that is so common in a lot of the other cases. So anyway, we made an early diagnosis, and we did find that she had a tumor, had an ovarian tumor. I happen to have gotten fairly close with the patient's mother, and the patient grew up and went to college and got a good job and got fired for some weird behavior at work. And her mother called me up and said, I think she's got this again. And said, but I took her to the doctor, and they kind of laughed at me, so talk to your daughter about being more polite so she can keep the next job, and it doesn't seem to be anything wrong with her. And so I called somebody else. I said, well, I don't know, you want to know more about this girl's history, but I'm just suggesting that you check her other ovary. She did have another tumor in that ovary, and that second episode didn't turn out to be so terribly severe, although she lost her first job. But I never would have thought, when I was much more strict in my boundaries between infectious disease medicine and psychiatry, that I would ever, see this kind of weird blend. But keep it in mind, if you start seeing weird blend, you say, maybe we should think about. So that's really pretty rare and odd. It may not be so rare, and it may not be so odd. Odd behavior is everywhere these days, so who knows. Some people even think that schizophrenia might be one of these autoantibody diseases that develops somebody for reasons that are not known. And this book is a novel, I think, or a book, Brain on Fire, that is talking about that. So maybe an exaggeration, it may be an overcall, but there's a possibility that there may be some biological reasons. And when you think about schizophrenia, you would think, well, there may be something strange really happening, because it's usually happening in young adults who are late teens who have been reasonably normal up to some time, and then they have a break, and then their life changes quite a bit. And it looked like they had all the abilities to have a normal life before that happened, in certain cases of schizophrenia. Okay, thank you. That's it.